Right, so I think we can start. So, good afternoon, everyone. And on behalf of the Neurology Academy, I'd like to welcome you to the second webinar of a series of the Uro-neurology Academy about intermittent catheterization in neurological patients. So thank you for joining us at this noontime webinar. And at the outset, I would like to introduce you to the faculty. So maybe if we go to the next slide, please. So myself, Jalesh, I'm a neurologist based at University College London, and I am a uroneurologist. We have Ruth Stross, who's the head of nursing at the Neurology Academy and is a neurology specialist nurse at Kingston Hospital, and Sharon Gill, who's the lead nurse for neurourology at the Royal National Orthopaedic Hospital in Stanmore. So this next hour or so will be sort of taking you through what we would hope to be a lively discussion about intermittent self-catheterization in the neurological patient. And if we could perhaps have the next slide, please. And essentially, the background is the pressures on bladder and bowel services that we are all familiar with in our day-to-day practice on the NHS. And so the objective is really around sort of who should step up to cover this discussion about bladder symptoms, intermittent self-catheterization with individuals with neurological disease who require ISC. What are the challenges for people with neurological disorders? What are the tips and tricks for management to ensure ISC is successful? And we end with the case vignette, and that will then ease us into sort of a question and answer session. If we could move on to the next slide, please. So we've broken this down into essentially there were three parts to this. There's a short introduction, sort of about the indications for the neurological conditions where intermittent self-catheterization may be required by myself. And then Sharon will take us through the tips and tricks of managing intermittent self-catheterization, and Ruth will lead on a complex case study. So we hope that this will sort of generate questions. And so if you do have questions, do pop them into the chat box, and we will sort of field those questions at the end. So without further ado, I am going to now share my slides. Right, so I hope you can see my screen. And so I will be taking you through the indications for intermittent self-catheterization following neurological disease. And that's just sort of my list of disclosures. And I hope I can convince you that none of these sort of conflicts of interest will influence what I have to say this afternoon. So when we think about neurological disorders and bladder problems, we think about the storage dysfunction that happens following neurological disease, and then the voiding dysfunction occurs. And if you think about in terms of sort of the dysfunction at the level of the lower urinary tract, conditions that result in incomplete bladder emptying and urinary retention can be either if there's a low pressure, low flow void state, for example, if the detrusor muscle is underactive and so essentially the pumping mechanism is not occurring and the individual starts to retaining urine from that. Or on the other hand, the problem could be at the outlet of the lower urinary tract where there's a high pressure, low flow void. And this most commonly occurs in the context of an impaired external urethral sphincter relaxation, where what we call is detrusor external sphincter dyssynergia. So in the context of neurological disorders, from a neurological perspective, we like to classify these in terms of conditions that are suprapontine, those that are sort of infrapontine or suprasacral, so essentially your spinal cord disorders, and conditions that are essentially involving your sacral cord, your conus medullaris, or infrasacrally, such as the cauda equina, the peripheral nerves. Now, in conditions where there's a suprapontine lesion, such as stroke or Parkinson's, in general, what we find is a rather efficient system of voiding. And so the post-void residual volume is low. And as a broad generalization, individuals with these conditions you will never see in an ISC clinic. Of course, there are exceptions. Now, it's generally the patients with spinal and sacral infrasacral lesions where you find in an ISC clinic So in the context of a spinal cord lesion, for example, there's storage and voiding symptoms, and this is driven by this detrusor sphincter dyssynergia, whereby the detrusor muscles is sort of contracting concurrently with an external sphincter when the command to void is given, resulting in incomplete bladder emptying. And with a lesion that's affecting the pathway to the lower urinary tract, such as at the level of the conus or infrasacrally, it's an underactive detrusor that predominates, and patients present with predominantly voiding symptoms. Now, this is all very good at the bedside, but what we find in clinical practice is that voiding dysfunction is often having multiple contributors. And if you take multiple sclerosis, for example, patients can have a combination of factors. For example, the same patient who has an overactive detrusor in a storage phase may have an underactive detrusor during the voiding phase, and therefore having hypocontractility and this contributing to voiding dysfunction. But they may also have a detrusor sphincter dyssynergia, resulting in an obstruction, a dynamic obstruction to flow. Now, assessing voiding dysfunction is core to any guidelines in evaluating the urological patient. This is, for example, from the EAU, from the European Association of Urology guidelines, where measuring the post-void residue is an essential bit of the assessment of your neurological patient. This is a guideline from the International Consultation on Incontinence, now a few years old. Well, once again, the PVR assessment is part and parcel of the clinical assessment. And many of you might be familiar with this sort of algorithm of the first-line assessment of multiple sclerosis patients with urinary symptoms. Once again, very high up in the assessment is measurement of the post-void residual volume. And conventionally, we measure the post-void residual by a bladder scan or ultrasonography, and less commonly in-out catheterization. And why it's crucial to assess the incomplete bladder emptying is that we know that if there's a reduced functional bladder capacity from retention, that this itself can worsen the storage symptoms. We know that stagnant water is a breeding ground for bugs, and this can predispose to recurrent UTIs. And in certain neurological conditions, such as spinal cord injury, advanced multiple sclerosis, or in spinal dysraphisms, we know that incomplete bladder emptying invites a greater risk for developing upper urinary tract damage. Now, I suppose the question in all of our mind is, well, is there any other way that, as clinically, that we could suspect that the patient has incomplete bladder emptying? So you're at the bedside, maybe a bladder scanner is not available, in-out catheterization is not feasible. Might there be any sort of indicators from the history that might make you suspect that there could be incomplete bladder emptying? And of course, we go by symptoms. So your voiding symptoms have hesitancy or poor stream, incomplete bladder, or a sensation of incomplete bladder emptying or double voiding. But these are not always reliable, and there are several studies that have shown a mismatch between voiding symptoms and the post-void residual volume. And of course, a neurological patient who has sensory impairment may not perceive a sensation of incomplete bladder emptying as compared to someone who's neurologically intact. Another possible history of a pointer might be if the patient tells you about small volume voids. Of course, this could be from having an overactive bladder and voiding quite frequently because of overactivity. But another possibility is very much that perhaps most of the volume of the urine is remaining in the bladder, and it's only small voids that come out. Another sort of indicator, which is very indirect, is sort of if the patient starts to develop recurrent urinary tract infections, particularly if they're having a progressive neurological condition such as multiple sclerosis or a neurodegenerative condition such as multiple system atrophy. The patient, if they start developing UTIs in the course of their journey, that could be another sort of could raise suspicion about incomplete bladder emptying. Another very soft sign is nocturnal enuresis in an adult, which is actually quite uncommon in your adult neurological disorders. And so if a patient starts telling you about bedwetting, once again, maybe an indicator of urinary retention. But these symptoms and signs are very low in terms of specificity and sensitivity, and this is why it is crucial in the assessment of the patient to measure the post-void residual volume. The other question is really about whether a standardized questionnaire might provide this. So us asking the questions and then contrast having an objective standardized questionnaire there is a difference. And so an example of a questionnaire is the urinary symptom profile, where there is a specific subsection there called the low stream score. And what you can see on your screen are essentially three questions which form from which this low stream score is computed. And a study that was run at UCL just a few years back showed that actually in patients who are being referred to a neuro-urology unit, that the post-void residue volume as measured by a bladder scanner correlated with the low stream score in the urinary symptom profile. And in fact, by measuring the area under the curve, what was found is that a cutoff value of a ratio of this low stream score and the total USP score of 0.515 and above had a sensitivity of picking up a elevated PVR of 92%. So it is possible, but I think the message clearly would be that though there are indicators, measuring the post-void residue volume is crucial moving forward. And you will hear from Sharon about the different techniques of intermittent catheterization, but also in terms of differences between sterile and clean intermittent catheterization. Now, the jury is out in terms of when to initiate, but essentially the commonality in terms of the discussion is that there is most often incomplete bladder emptying. There is no hard core evidence in the literature about what is the sort of cutoff value. In general, if you take a cohort of men, say with prostate enlargement, generally the value of more than 300 ml is considered as a cutoff to initiate intermittent self-catheterization. Generally, in the neurological patients, the cutoff is much lower, just because we know that patients with a neurogenic bladder will have a small capacity bladder, plus there will be high pressures from overactivity, and also there will be a greater risk for upper tract damage. And generally, a figure of around 100 or 150 ml is generally considered as accepted. However, the exact volume very much depends on, very much bespoke, depending on the individual characteristics of the patient before you. And there are studies that have demonstrated the benefits of intermittent catheterization, it depends on the population studied and the criteria for starting intermittent catheterization. And the studies which have looked at UTIs have generally shown that there's a less frequency of urinary tract infections after initiating catheterization, though recently a study has been published that shows the contrary. Though we know that stagnant water is a breeding ground for infections and ISC can reduce the risk of UTIs, this may not necessarily be the case in all patients. We know that initiating catheterization can improve the quality of life, but also improve refractory urinary incontinence that's otherwise refractory, particularly if there is incomplete bladder emptying. And also we know that it reduces the risk for upper urinary tract damage. Now, what happens over time is that you've initiated the patient with catheterization. Do patients continue this throughout the course of their neurological illness? So there's very few studies that have looked at this, but this is a large population-based study. And this is the population of patients with spinal cord injury in the United States, where through the series of veterans hospitals, it's possible to sort of to document ISC use. And in this study that was sort of looked at sort of use of ISC and other sort of voiding techniques over a 30-year period, it was found that actually in patients who initiated catheterization, so if you look at the graph on the right, on the left-hand side, those who initiated catheterization in green, that in that first 5 years, that the numbers who were continuing with intermittent catheterization plummeted to 50%. And thereafter, the patients tended to continue with intermittent self-catheterization, though you find that numbers do gradually reduce. And by 30 years into their spinal cord injury, you find that it's only a quarter of the patients that were initially started with catheterization do continue it. Now, there are several factors that can predict sort of continuation with ISC. And this is just one study I've selected from Dorian McClurg, the Cosmos study, that found that ongoing support from healthcare professionals, support in the home environment, and a perceived improvement in their urinary symptoms, such as nocturia, were the strongest predictors for continuing with intermittent catheterization. And the predictor for discontinuing catheterization was developing of a UTI during the early stages of IC, which probably comes as no surprise. So there are different barriers which perhaps would then sort of influence continuation of catheterization, and these include internal and external factors, which Sharon will take you through in depth. And I think this is perhaps a perfect time to actually stop this presentation, and I'll pass on to Sharon, who will then take you forward on sort of the tips and tricks of ISE and how to overcome these barriers.
Thank you so much, so much. So an absolute pleasure to come and have a chat with you regarding intermittent self-catheterization. It's certainly been part of my bread and butter work with neurological patients for many, many years now. And just as Jalesh was referring to, is how you teach it, how you manage it, and how you follow up leads to success on patients and satisfaction and compliance and concordance. But ultimately, when you first start to talk to our patients, when you have to have that conversation, they're going to go through different emotions and have different questions. And probably the first part of your consultation with them is going to be answering or deflecting or answering questions that they have. And this comes from panic, from anxiety, it's shock. It's almost like another thing to say, oh God, that's another thing going wrong with me now with my MS or with my spinal cord injury. You know, not only am I affected physically, but now you're telling me my bladder's been affected, my bowels have been affected, my sexual function's been affected. So ultimately, they want to know, why do I need to do this? If I'm peeing okay, yes, I wet myself a little bit. Why do I need to bother? And that. So be prepared for all those questions when you have that consultation with them. Don't rush. Don't feel that you have to achieve everything on the first time that you meet with them. This is a process going forward where you're building that trusting relationship between you and them, so that you then can sell them, unfortunately, on the idea of actually to do intermittent catheters, but to understand how that can fit into their life, their work, their travel. And also to remember they have a choice. They have a choice not to do it, but it's an informed choice where you have to explain the risks of not doing intermittent catheters, what could potentially happen, what those red flags are, and what we would do about it. So whenever you're seeing anybody in a consultation, particularly regarding bladder dysfunction, the first choice is always stay as you are. But then do understand what that means, what the consequences are, what could happen, but also how we will look after them. We don't close the door, we always keep the door open. So hopefully that slide's not too small, but I'm very glad that Janice also looked at emphasised that paper, McClurg et al. I would definitely recommend having a read in it. So some really nice papers out there on success on intermittent catheters, but also about barriers as well. So when you have got that shock, that initial sort of feeling, oh my goodness me, what am I going to do? Allow time to talk, offer to have somebody else with them, either by themselves, a friend, a partner, if they want to, because sometimes a couple of pairs of ears are better than just one pair of ears, especially when you've been given what potentially is bad news regarding what you have to do for your bladder. So don't rush, take your time. I don't mind how many times they come back to clinic. They can come back as often as they need to for them to be comfortable, but also have all your facts to hand. There's nothing worse than going into a consultation with a patient and you don't know the background, you don't know what the residual is, you don't know the rationale. So how can you sell it to them if you can't then justify why it needs to be done? But also take into account not just their neurological condition, but their urology history. Do they have an enlarged prostate? Did they have a weak pelvic floor before? Have they had stress incontinence in the past? It's about looking at them holistically and not just the neurological condition. When it comes to how often, will this be forever? Well, you know, as long as you've got your neurological impairment, as long as your bladder's been affected, yes, you will need to do this. Whether that'll be forever, I don't know. There's new and different things happening in the market all the time and in research. I want you to be at the front of the queue. So I know looking after your bladder well and keeping it healthy and reducing infections by doing intermittents will put you into the front of the queue. And it's really important that your bladder management fits around your life, not your life around intermittents. And that's a kind of an area of concern for me. We talk in the clinic about work, travel, how to fit this in, how to have sex and do intermittent catheters. Make sure you empty your bladder before and after, so you've got no risk then of leakage. But also the important thing about talking about medication to calm the bladder down when you have overactivity. And there's some really nice ones on the market, particularly the new ones, the beta-3 agonists, mirabegron, that don't have all those horrible side effects that anticholinergics, antimuscarinics do with dry mouth, blurred vision, memory and concentration problems. So the beta-3 agonists have really opened up life and quality of life to suppress the bladder. But also those Botox we can give to the bladder now, and that means a lot of our patients can come off medications to stop overactivity. But of course, whenever you're given any medication to calm the bladder down or Botox, your risk of leaving more urine behind, increased residuals, and having to learn intermittence is an absolutely essential part of the informed consent process. And whatever they say, try and, as Whiteheister said, just try and turn a negative into a positive. Try and see, well, the barriers that they put up, what can we do to break those down, to work out how they can do this? And again, back to patient choice, you've always got status quo. You know, I don't like the band myself, but you can just stay as you are. That we talk about the red flags and actions and how we're going to monitor in. But obviously, MS is a progressive disease. It can have periods of quiet and stagnation, but then progression. So it's important that they understand that after intermittent catheters, you do have other options after that. If it got to the stage you couldn't do them, then maybe you might want to consider a suprapubic catheter or even a diversion such as a mitrophanol to catheterize through your belly button down to the bladder if it makes it easier, particularly for ladies, for accessing the urethra. And you've also got other options such as diversions to a urostomy. Now, it's already been mentioned, a lovely paper by actually Bowel and Arafu actually in 21. Again, I really love this paper when it talked about those internal, external barriers and that. And I think the left-hand side, you know, is the physicality, it's the eyesight, it's the mental dexterity, and we'll talk a little bit more about that a bit later. But it's also the cognition, depending on the age of your patient. How good is their memory at the moment? Does, you know, MS can affect memory sometimes. It can certainly, in some of the patients I've seen, cause quite a lot of health anxiety, particularly if they've had a delay in diagnosis and it's been some time before they've got to an expert. Again, you're building up that relationship, getting to know them getting to know you. So you'll know then how easy or what help and aids they're going to need to do those intermittents. But also be aware of, you know, a lot of our people, including myself, are very big. It would be quite difficult to catheterize and reach down and be able to see where you need to go over your tummy. So there's things we've got out there that can help with that as well. And then lastly, it's about hypersensitivity. It's about that stigma. Oh my gosh, everyone's going to know I'm doing this. So we talk about privacy and dignity. We talk about how to travel, go to your friend's house, go to a hotel, to a restaurant, to go abroad and be able to do those intermittent catheters abroad. And that is discussed within the clinic, and we'll always find a way for that to do. But ultimately, external barriers, that lack of knowledge, so and insufficient training and instructor confidence is so key. There's definitely a direct relationship between the person that's teaching the intermittent catheters, how it's discussed and how it's taught, and how it's followed up, particularly to do with the success of the patients then continuing on with intermittent catheters. So it's always keeping that door open. There are so many different catheters on the market. Oh my goodness me, we're overwhelmed with choice now. And all of them now are single-use catheters. It's rare that you'd find one that's repeated use, primarily because there's a lot more association with urethritis and recurrent infections and that. But there are small little ones on the top left-hand side. I particularly love that SpeediCath Compact and Eve for doing on the toilet. I particularly like the Hollister one. It's slightly longer, got a bigger hand grip. The one in the middle, the little green one with the knobbly bit at the end, that's really good if you've got sphincter spasm or enlarged prostate. Again, with a Tim and tip on the right-hand side next to that, if you've got a high bladder neck or a prostate, bearing in mind we're looking at them holistically, not just their neurological conditions. And depending where they're doing the catheterization, ideally on the toilet is the best if they can physically do that. But there's ways to do an intermittent catheter in a wheelchair. I've even got ladies that stand up and catheterize, or ultimately they may want a bag on the end of their catheter so they don't have to worry about any contamination of their clothes, of their wheelchairs or their seats as well. There's always a way around things. And again, we've got different sizes. We tend to sort of go from a size 10 to 12 for a lady, 12 to 14 for a bloke. But some of our neurological patients, we actually, even ladies, use a 14 only because it speeds up the drainage. And that, obviously, with MS, we're dealing more with adults and elderly patients as well. But in spinal cord injury, which is a big group of my patients, I'm also dealing with children as well. And then the sizes become smaller for them. But there's lots of aids, as I said. There's hand grips, leg spreaders, mirrors, labia, penis holders, and also sheaths, convene sheaths that you can use that you can catheterize through. So this is some of the grips on the top left-hand side. I particularly like the low fric one bottom left, the blue one. That can attach onto any catheter that you have, and you'll be able to get your intermittent catheter in. The gruesome one in the middle top is the labia spreader. I'll be honest, I've never used it on any patient. I've seen it. I don't particularly like it. There are techniques that you can use with your hand to help them to open up the labia to be able to see where they're going. But ultimately, with men, it's a little bit easier to see where they're going to identify the urethra. But with women, obviously, a lot of the time you're teaching them to catheterize blind almost. So they're doing it by feel. But starting with a mirror to begin with can help them to look at their anatomy at the beginning before you start intermittents, so they understand what they look like. And there's lots of different devices out there that can hold the legs apart if they've got spasms or their legs are going together, which are spreaders. There's a balloon based one, and there's some more metal ones. And then with blokes, we've got penis holders. If you use one of these little sort of spongy devices, you can wash them with soap and water, and that to hold onto the penis, it holds it upright. That means they've got both hands free then to catheterize with. But we've also got a sheath, which is the K plus IC system. So for those people men that still leak in between intermittent catheters, wearing a sheath in between is a better option than a pad to protect their skin. And this is a sheath that actually can be retracted back over the penis that you can do an intermittent catheter. The rationale for that is that if they're leaking and we're still trying to find a way to get them dry, then by having a sheath that you can catheterize through means you're not taking a sheath off 4 or 5 times a day, which would obviously affect skin. But ultimately, there's different positions they can get into, and that will be the next slide coming along. Looking at clothing, there's some really nice Manfred Sayre and other websites out there that have clothing for men and women that makes it so much easier to catheterize if you're a wheelchair user or standing. But ultimately, what we want them to do is be able to wear anything that they want to wear without constantly having to worry about they're going to be restricted on wearing shorts or shorts. Dresses, but also for men as well with wearing a suit. They want to be smart. I hate it when I see people always wearing jogging bottoms because it's easier, and that I think they should have choice. And so these companies actually make specific trousers for men that have much longer zips, which means that when you open it up, it's much easier to access the area. For women, it's about looking at the tightness of jeans. That's another big one for me. Can they get their jeans down easily to be able to catheterize? So this is important to talk through. We used to recommend something called bungees, which are the things sometimes you see at supermarkets with shopping trolleys where they keep the trolleys together, and you also use them on the back of a motorbike. We don't tend to advocate that now. We used to get them to latch it onto a strap at the bottom of the wheelchair and then the big other bungee bit to go onto their trousers. However, it's a very sharp implement, so probably not so good to do, but it did get everything out of the way to be able to see where they were going. And then sometimes we'll recommend also extension tubing. So if someone can't get on and off a toilet and they need to stay in a wheelchair, then by doing an intermittent catheter either with a bag on the end or cannibalizing a night bag, cut the bag off, just use the tubing and use that tubing to fit into the end of your intermittent catheter. And then the other end can go over the toilet and you don't have to worry about where the urine is actually going. But the important thing is we don't want them to take a suitcase with them every time they're going away to do an intermittent catheter. We want to keep it as simple as we can with the least amount of aids that they can possibly get away with, so that they don't have any fears or worries about going anywhere that they want to. But any outcome, any success for doing intermittents must require regular follow-up reviews. It's absolutely essential. There's no point teaching somebody, ringing them up once saying, "Oh, you're okay, I'll leave you alone." No, you have to follow them up every week for a few weeks, particularly because of that risk of developing UTI as your body gets used to doing an intermittent catheter. But also make sure that you're checking in regularly then every 3 months. And then it's a case of they'll go back into the medical clinic. So they've always got constant monitoring and constant review. So this is one of my colleagues, Liz. We were looking at different positions that patients potentially could get into. Some of them are dangerous, particularly the ones where you put your feet over the toilet. You know for absolutely your foot's going down that toilet, and that ultimately, if they can get on and off a toilet, it's much, much better to be able to do an intermittent catheter. If you have to do it in the wheelchair, maybe the top left one, putting your leg over the side, and say the bottom right one, just moving your pelvis forward and then tilting backwards to be able to do an intermittent. It's so much easier for blokes, I have to say. You are so much luckier that you can literally just sit, maybe lean back a little bit, open up your trousers, and there you go, you know where you're going. Now, the buzz thing in urology, in neurourology and intermittent catheters, recurrent urinary tract infections. It is what is everything is going on about every conference, every meeting I go to. When we're looking at published information, it's about how do we reduce UTIs, not just UTIs and intermittents, but also indwellings, those catheter-associated UTIs. But we know the evidence is out there that intermittent catheterization, making sure the bladder is completely empty regularly throughout the day, definitely reduces an infection, and definitely because it's an in and out catheter, not there all the time, you don't get the biofilms building up. You don't get that risk that you would get with an indwelling catheter. Now, it is very common to see a positive urine dipstick if you test it when you're doing intermittents. It will show nitrates and leukocytes. So therefore, we only treat symptomatic UTIs. And symptomatic means a temperature, shivery and shaky, offensive smell in urine, blood in the urine, pain on passing urine, incomplete emptying. It is not smell, it is not colour. So just a whiff of urine and cloudy urine is not an infection. And that's part of your patient education. Is so important to give them so that they're not overusing antibiotics and building up resistances. But there are lots of things that they can do to help prevent infections. Cranberry-juice tablets, although you can't take it with warfarin, it affects those levels, helps with building up a biofilm so it helps with a gag layer, so therefore preventing that bacteria going into the bladder wall. Probiotics, if you can replace the flora within the gut, it's shown significantly to reduce infection. D-mannose is a herbal extract, and bowel management. I can absolutely guarantee if you're going to get a UTI with intermittents, it's either going to be E. coli, enterococcus, it's going to be from the bowel. So therefore, when you're talking about intermittents, when you're talking about bladder management, you must talk about bowel management as well. And certainly I know work that Professor Emmanuel did is that he showed that transanal irrigation, complete emptying the bowel, reduced urinary tract infections by 80%. So that goes to show how important bowel management is to prevent recurrent UTIs. I'm just going to skip over this next slide. I just want to go to the gag layer. A lot of the research and a lot of the talk now at the moment is about replacing the gag layer of the bladder. This is the natural lining of the bladder that's made up primarily of water and some other things as well that protects the bladder muscle and that. And when you have recurrent infections, as you can see in that next little bit of the slide, bacteria, it breaks down that gag layer. That means the bacteria has direct access towards getting into the muscle, and that's when you start to get recurrent urinary tract infections. So a lot of the work now is about how can replace the gag layer to stop those recurrent infections. You can give gentamicin into the bladder. We've been doing that as a research study here, and I know they're doing it at UCLH, and we're now doing it on a named patient basis. But ultimately, I want to get Uro-neurology here at Stanmore for my patients. I'm getting them referred to other hospitals, but Uro-neurology is an installation that you put into the bladder through your intermittent catheter, or you can actually put it directly up through the urethra. You do it once a week for 4 weeks, once a month for 5 months, and it can prevent urinary tract infections for up to 2 years. There's a vaccine out that's being tested at the moment in some research studies. It's a spray. And lastly, I just want to come on to some of the challenges and adapting. COVID hit us all quite badly, particularly our service. All of us were redeployed back to the wards. We were a COVID receiving hospital, but that meant that we couldn't necessarily abandon our outpatients. And we still had patients out there that were still having telephone clinics and needed to learn IC. So we adapted. And our patients adapted, and we used team meetings. And I can't tell you how many times on a Teams meeting I was with a patient with their phone in the toilet, talking them through how to do intermittent catheters. And it worked, and we managed it, and we did it. Obviously, there's nothing better than face to face, but we found a different way to manage. And certainly after COVID, we did lots of things on how our recovery programs catch up and make sure that all our outpatients were safe. Our catheter companies do actually give lots of support. They actually have nurses themselves that can go out to see the patient in their home. It doesn't devolve our responsibility to them, and we do need patient consent. But it's really important that us as clinicians have a trusting relationship with that catheter. We know the nurses and what they're teaching. But certainly when it comes to hospital-based nurse-led clinics, it has to be face-to-face, ideally. Apart from when it was COVID, we do give at least an hour, and they can come back as many times as they need to. They don't need to achieve everything on the first visit. What's also important, even myself, 30 years on the job, I still come back and chat with my colleagues and my team and say, I've got a particular patient. This is what I've tried. It's working, it's not working. Any other ideas? And we will talk, well, I tried this worked. So it's important that you're not on your own. You do discuss with your colleagues and make sure that you're getting those other approaches and fresh ideas. And that follow-up is so, so essential. There's great peer support networks out there. There's Facebook pages for the Cauda-Equina syndrome patients, spinal cord injury, MS. Only someone who has to do this understands what it means and what it's like. It's fine for us. I've been teaching intermittent catheters for over 30 years. I have had to do intermittent catheters myself for other reasons, but I don't do them all the time. So you need to talk to other people that having that shared experience. And also there's some really nice things coming out from Girth at the moment, the North Central London evaluation of services, which has all been started post-COVID to look at how we're going to reduce all of our waiting times, but also about sharing things. So if one hospital is struggling and the other one has capacity, why don't we just share our patients? All of it is for their benefit. And ultimately, we've got lovely guidelines. We've got the EAU guideline. We've got the NICE guideline. It's the gold standard intermittence. And also improving quality of life, reducing infection actually has been shown, according to them, to reduce the risk of an MS relapse. We know they will get relapses, but if we can reduce the number of times and the length of time, that's great. And neurological conditions are a long-term condition, and we have to be adaptive to the variations in their journey. But ultimately, they are controlled, they are empowered, and they have informed decisions. And that's the end of my talk. Thank you very much.
So I'm just going to take you through a case study. We had quite a big discussion about this between the three of us because we wanted to pick someone that we felt reflected kind of the conversation and the learning that we have within this webinar. So this, if we could go to the next slide, please. So please do ask your questions. We have this amazing opportunity to ask Jalesh and Sharon questions around the case study and any questions that you have related to your own services and your own clinical practice. So please do put them in the Q&A. Next slide. So when we were talking through kind of looking at a case study, we looked at sort of different ages and stages, and I guess we've settled on a 38-year-old gentleman with multiple sclerosis. I guess part of why we picked this is that lower urinary tract symptoms affect 2/3 of people with MS. The prevalence, which is self-reported, is around 68.4%. And then on testing with urodynamics, it's 64%, so pretty similar. And interestingly, men report symptoms at baseline. So at baseline, it's around 48%. This was in a study of quite a few patients. At baseline, 48% of patients reported more than one symptom of lower urinary tract symptoms. And then at 3 years, it was 52%. And at 6 years, 71%. So, you know, huge changes in a short period of time. And I think that's kind of where we were coming from. It obviously has a massive impact on the person and also on the cost around their care. So we're hoping to sort of pull out some of those factors within this. So Nick is male, he's 38 years old. He was diagnosed with multiple sclerosis around 7 years ago. He is married, he has 2 children. He has a daughter who is 10, a son who is 8. He works in IT. He is office-based, but during COVID, he was asked to work from home. And then since COVID, there's been the kind of push to come back into the office and a very strong encouragement. And he's found that change difficult because obviously adjusting to having a family, growing family and all the dynamics around that and the changes with his own symptoms. He also, his own hobbies is he's a singer in a band. He is the football coach for his daughter's team. So with regards to his kind of history from the bladder point of view, he has a 4-year history of urgency and frequency. He's had 3 urinary tract infections, and each time he's obviously had an increase in his other MS symptoms. He didn't really talk about it to start with. He kept it quiet and just got on with work. He got to a point where he was finding that it was pretty intrusive, and he was struggling within his work environment. Working in IT meant that he needed to be sitting at his desk, and he was feeling a bit like it was being noted that he was going to the toilet more frequently, and he was starting to find that his mood was affected, and his confidence within his work environment, at which he'd felt incredibly confident before. So that kind of combination of the urgency and frequency had impacted his independence, and he did have a kind of feeling that he wasn't completely emptying. So he was seen by the MS nurse, and then he was referred, and his urodynamics did show a neurogenic detrusor overactivity. He was able to avoid 150 mils, but there was a residual of just over 100 mils and detrusor pressure of 45. So I guess what would be really useful to talk through now with both of you, Jalesh and Sharon, is kind of there's so many factors within this, and both of you have brought through a lot of this conversation already within the slides that you've shared. It's a multifactorial journey for this person. The kind of the psychological impact, the physical, the social effects, the work effects, and also in combination with that is his experience of with the NHS so far. And likely that's been, he's seen his GP, he has a neurology team, an MS team. He's already been referred to urology. It might be community bladder and bowel services. It might be hospital-based urology services. And then the kind of wider considerations around the impact of his hobbies and what he really wants to do with coaching and supporting his daughter within the team and playing in a band, and these things are kind of out of his control with regards to timing. And the fact that there is an impact on his MS, and he's trying to juggle that and work out what's the bladder and what's the MS. So I guess one of the things that I think that we struggle with, speaking for myself as MS nurses, is to work out when we have that conversation. And I know that we're moving very much towards having pre-clinic assessments so that we can give patients the opportunity to talk about symptoms if they don't want to bring it up in a clinic environment. So we give it to them prior to them arriving, and then they can write down that there are problems. And sometimes that's where we get some of these conversations that arise, because I know that there are patients that will have these issues for years and they don't bring them up. So I guess what would be really helpful is to discuss how we can help facilitate those discussions and find out early, because we know there's a huge percentage of patients with other conditions that will have issues within a very short period of time from diagnosis. So I don't know who wants to chip in first, whether I go to you, Sharon, just to kind of comment and any thoughts on this.
So the thing is, you said and we talked about it's about giving time, and what worries me is that when the patients don't say anything. So within our team, we will say something. We call it permission to speak. So therefore, you have to ask those difficult questions. You have to say to him, you have a neurological condition. Even if he hasn't told you about any of his bladder symptoms and he's kept it quiet, way I would approach it with him is say, you have a neurological condition. Sometimes this neurological condition affects bladder, bowel, and sexual function. Have you experienced any of that? And normally then that opens up the door and opens up the floodgates, say, well, actually, yes, I have. But obviously, from a nursing perspective, it's about you having that confidence that when you open up that door, that you're going to be able to answer those questions for him. But as I say to my nurses on the ward, you're not expected to be a specialist. You don't have to be an expert. What you have to do is give them permission to speak. And they will do it at those times, as we know in nursing, when you're in the most vulnerable position, catheterizing or doing something with them, or giving them a wash, and they want to talk about their sex life. And that, so it's almost like give them that time to talk. And if he doesn't prompt you or say, well, actually, no, everything's fine, I'm absolutely okay, no problem at all, Then ask a little bit more detailed questions. Say, okay, just tell me, how do you go to the toilet? Do you pee on urge? Do you have any frequency, urgency? So do that specific question, and then ask that about the bowels, and then ask it about sexual function. If all the barriers came down, then that's okay. He's saying stop. But as long as you've said, okay, just so you know, I am here if you need me. If you're having any of these symptoms, please come and talk to me.
Thanks, Sharon. Jalesh, what are your thoughts? What would you be looking at?
Well, where do we start? I mean, this is a very typical sort of a case scenario of someone with MS, full on life, and then MS hits. And I'm pleased to see that there's a growing recognition of non-motor symptoms. And I think in most of these sort of the standard neurology clinics now, there are sort of leading questions now being asked about the bladder. But I think, as in this case scenario, what often happens is that patients often sort of underplay their symptoms, and it's very personalized. You do have some patients who actually come out with the symptoms, others who sort of accommodate and put up with it for a while. And so I think that rather than the symptoms per se, it's actually looking at it in terms of the impact to the symptoms. And I think when you start asking about sort of how things are at work or at home, how is sort of the coaching job getting along? And then, how's the gig going on? And then you realize that, and then it comes out that actually the urgency is there, the frequency is there. And I think when going through that, starting through the impact, then working down to the urinary symptoms, I think you'll find that patients are often much more receptive to acknowledging the bladder symptoms. I suppose in this sort of vignette, what's also there is the UTIs, and of course, when it comes to urgency, frequency, a bit of incontinence, I think, but you'll find that patients will put up with it. But when it comes to a UTI, then of course, one needs to seek medical attention. And then of course, it's that question: why are the UTIs happening in a young man? And particularly we see, and I imagine that there was a period of time when the patient was not having UTIs. Now is beginning to experience UTIs. We find that the post-void residue is 100 ml. So it would seem that perhaps as the neurological disease has progressed, that these UTIs have started as well. And I agree with Sharon in terms of the relationship between the bowel and sexual problems. You mentioned about sort of Professor Mandel's study. I think it just goes to show once again that sort of that interrelation. And we have to find sort of where we can start with, and perhaps you start with urinary, which is perhaps something that most patients would probably be ready to open up about. And then move into sort of bowel, and then sort of issues with intimacy. There are now a couple of questionnaires that are available that can actually are actually sort of pitched towards patients. In fact, they're sort of they're sort of pitched in such a way that it allows patients to recognize their problems, and actually they can come to their healthcare professional and say, "Oh, I've got such and such symptoms." And then of course the conversation is it from, an enlarged prostate? Is it from having children? Or could it be from my neurological disease? And that sort of gets the discussion going.
Thanks, Jalesh. So I don't know who wants to answer, but we've had a question come in, and it's on something that I have to say, you come across quite frequently. What happens when you've, explained that there is the possibility of say things like ISC and medicine and other treatment, and just getting a lot of pushback, and you can tell that he's obviously a bit scared. This is something new. He's young. He has a young family. Whole idea of catheterisation changes his kind of sexual image, and he just can't get his head around it. What would be your thoughts about how to manage that? Who would like to go first?
It's one for Sharon.
I think it's about, don't rush, give time, build up that relationship, build up that trust, get to know him, let him get to know you. I think it's very harsh to go in and quickly say, oh, you need to do intermittence. No, you need to take that step back. As Janice was saying, it's about talk about different things, how his bladder and his infections have impacted on work. Has he had days off? Is he being scrutinized for that? It's about then also talking to him about his tests and say, look, this is what we've seen. This is what we found out. So when I start teaching somebody intermittence, unless they absolutely have to do it 5 times a day, I start with once a day. So build it up slowly. Don't go immediately and say, what you mean I've got to do this 5 times a day? No, let's just start with once a day. Just do it at night. Make sure your bladder's completely empty. Let's see if you get a better night's sleep from that, which means that you recover a bit better in the morning. So you're a bit fitter for work. You're not getting up during the night. And so it's about slowly taking it on. And just give it time, and regularly talk and regularly follow up. As I said, just try and look at those different things regarding work and his hobbies and his family life and what he wants to achieve. His quality of life will help you then to introduce what he needs to do to manage his bladder.
Do you want to add to that at all, Jalesh?
I think Sharon has covered most of it, and I will say I've never met a patient who's actually looked forward to catheterization. The patient comes to clinic and there's a post-forward residue that's at 200, 250, and it's sort of initiating that discussion. And there are patients who will come for repeated follow-ups where we just sort of, we sort of reintroduce that or revisit catheterization. And I think for each person there is sort of a period of time that one has to give, and I think the compliance would be much better when it comes from the patient, when they mentally feel that they're up for it, and it might even take months or years. Of course, in the process, we need to ensure the patient is safe. I mean, if the patient is having recurrent UTIs, there's an episode of urosepsis, a hospital admission, then then I suppose that would be a prompt, but also patients should therefore be followed more often. Or perhaps you find that the lower urinary tract is unsafe. That maybe the patient is having spinal cord injury, maybe they're a patient with MS in a wheelchair, for example. But even if there is, say, even an ultrasound that shows hydronephrosis, for example, how to sort of convey that to a patient to say that, look, there are upper tract changes, and I find that part of the discussion is actually the most trickiest. Whereas if it's a UTI or if there's incontinence, it's much easier to sort of to have a conversation about engaging with catheterization. But I think at Queen Square we're lucky to have a lovely nursing team who sort of engages well, quite similar to what Sharon was saying, those repeated visits and understanding the patient's perspective, where they're coming from, and then us trying to fit intermittent catheterization into that perspective, rather than it being more of a healthcare professional's perspective, which I think we'll often find the expectations are different.
Perfect. Thanks, Jalesh. One of the other things that I was thinking about is there's obviously been a complete change in pressure on services. There's been new roles, there's been services that have been lost within areas they may not have the same access to bladder and bowel or urology. So I guess the ideal is that this gentleman has as many appointments as necessary, but sort of thinking practically, at what point do you think who takes on that responsibility, or how do you, what would you say to someone that is saying, I don't have capacity to actually follow them up regularly, or who takes on that ultimately the responsibility at this stage for this gentleman to make sure he is followed up if he is still not wanting to go forward with any treatment?
I can start with that, and I think we have to recognize that this is a shared care approach, as is in for any symptoms, be it spasticity, be it pain. I think urinary symptoms will fit quite well into that shared care approach, where we may involve other specialists, but I suppose it's sort of in that journey of a patient with neurological disabilities who have multiple symptoms. This would be one amongst them, and we engage with each of the symptoms, and likewise we engage with the bladder as well. We find that that patients who are often sent to, say, maybe to, from a neurology to a uroneurology service, or to a urology service, for example, they will still be a neurology services patients. And so and I think it's very much sort of sharing what can be there, and having questionnaires, having some training and sort of assessment of urinary symptoms helps. What I find, however, is one of the barriers is actually getting the post-forward residue volume checked. And if you're lucky, you have a friendly radiology team where perhaps the patient can be sent down, but that's not very often. You then maybe rely on community services, but then to get a bladder scan or a PVR checked may take several months. And in the process, what happens is that we lose quite a bit of time in the patient's journey before initiating something as straightforward as an antimuscarinic or, as Sharon alluded to, a beta-3 receptor agonist. And I think part of the discussion is how a service can introduce a post-forward residual measurements in their practice. Whether it is having a bladder scanner, for example. And I can just say from the neurology perspective that neurosonology has come in a big way in neurology in terms of stroke. And so having a bladder scan, ultrasonography, and through ultrasound measuring a post-forward residual volume is no longer a big thing in neurology. Anecdotally, we just ran a hands-on course at the European Academy of Neurology Congress in Helsinki just last week, where we had neurologists coming in and learning how to scan the bladder. And we had a phantom bladder and we had a bladder scanner, and it was an incredible success. And not a single delegate at this course actually came back and said, this isn't my job. So I think a lot of it is just getting used to this, and I suppose investing in a bladder scanner isn't a big purchase as it used to be in the past.
Thanks, Jalesh. Do you want to add to that, Sharon?
No, just to say absolutely agree. I think sometimes I forget how lucky we are here at Stanmore that every ward has a bladder scan, every nurse is trained, every healthcare assistant is trained how to do a bladder scan. But that's because we have a lot of neurological patients here. We are a luxury, but yeah, I do appreciate in local services there isn't that luxury. And although bladder scanners now, there are loads of them are portable and handheld, not every continent service might have one there to offer. And it's such an essential service. So we try, as we said, it's multidisciplinary approach. We try and do one-stop clinics. So when they come and see us, they'll have either urodynamics or a flow rate, a residual. They'll see their rehab consultants. They'll see their urologists, might see bowel, might see sexual function. So maybe adapting those services where it is multidisciplinary team led to be one-stop clinics is probably more successful than making them come back 6 times to see different specialities. But it's whether your service can support that or not.
Thanks, Sharon. Liam Rice has actually, oh, sorry, Jalesh. Do you want to chip in?
Well, I have a question for Sharon actually about something slightly separate. It's about multi-use catheters. And I think the gold standard in the UK and many countries is a single use. But of course, I think we can foresee a comeback of multi-use catheters. In large swathes of the world, multi-use is still the first line in terms of intermittent. But we have the multi-cat study from Southampton. We'll know the results next year. And there's a separate study in the Netherlands, the COMPARE study, which is actually evaluating multi-use versus single-use catheters. And I think once these results become known, it'd be interesting to see how the narrative changes in terms of single use as multi-use. But what's your experience with multi-use? Just to, it might be a bit.
I've got some old school patients that are very environmentally aware, and this interestingly comes up a lot in the clinic. I don't want to use one catheter and throw it away. What about the environment? Is this biodegradable? It's not. These catheters have a massive impact on environmental, and patients are much more aware of this and worried about it. So yes, I'm really going to. Is it Mandy Fader, isn't it? Has been doing one of the big studies looking at reusing catheters. I'm really interested to see when that happens and what those results are. But certainly for those patients, old patients that reuse their catheters, you can tell their urine stinks, but they have no symptoms and they're fine when they come up for urodynamics. When you're trying to put an intermittent a catheter in for urodynamics, it feels like you're going all the way down, because I suspect probably they've developed potentially some strictures there or some scarring within that urethra because not using a lubricant to glide through. And that's what worries me. So I'm worried about the environmental impact of chucking these catheters away, but I'm also worried about single-use catheters and the risk of urethritis, infections, strictures, and recurrent UTIs. So there used to be a day when they used to just wash it out with Milton, put it into a sealed bag. I had one patient that used to just lick it, put it in. He was really well. And then I've got other people that do intermittents absolutely brilliantly and have recurrent UTIs that I can't find a rhyme or reason.
Well, I recall a patient who had something sewed into their belt where they can just put in their catheter, their multi-use catheter. They're out and about. They don't have boxes of catheters that they go around with or on holiday. They just sort of unbuckle themselves. They just take out their catheter, and then I suppose they leave it out for drying and put it back into their sheath. So I think it's very anecdotal. I mean, but it'd be interesting to see what studies show. Do you know if there are any sort of biodegradable catheters coming out? Is that something that you've heard?
I've not heard about biodegradable one, but certainly the well-spec catheters have changed the plastic, so it makes it more compatible to biodegradable, but it's not perfect, it's not there. Do you remember the old days when patients used to turn up with silver catheters? It was the girls, particularly pediatrics, who used to have a silver catheter that was reusable, but then you'd wash it out and you'd have to put it in the oven and heat it to a certain temperature to kill the bacteria and then wait for it to cool down to then use it again. So the practicality of actually using that was quite difficult, but I quite like the concept of it.
Thank you both. We've had a few comments and questions, so I'll quickly whiz through those. So Liam Rice has mentioned it's really important to give people the option of surveillance and reviewing in a few months, giving them the option not to have ISC. He finds that does help. I think that does help take the pressure off. I completely agree. And then someone's asked, can you please give advice regarding appropriate referrals once the patient reports the symptoms listed above? And I have to say, I do hear this quite frequently from MS teams and other neurology teams. Do you need to refer to urology or to the local bladder and bowel or to the continence team? There's so many different titles at the moment. What would you say would be the best pathway to go for the hospital urology or the community continence, or which direction?
Do you want to go first, Jalesh?
I was looking forward to hearing what you're going to say, but I think it's very much depending upon sort of the locality and the existing pathways, because I think when it could be a urology service, but it could be the community team. I mean, what I do know and is that having a urologist interested in functional urology helps quite a bit. And so if you do have someone who's interested in functional urology, then of course there would be a natural care pathway that could be formed. But I do feel it's very much depending upon sort of existing pathways. And I think each locality will have a different pathway. Don't know what you feel, Sharon.
I think it's interesting that having been in neurourology for so long now, we're so lucky that, we keep our patients for life. We don't discharge our patients. As long as they have their conditions, they are with us and they'll always be with us. And I appreciate not every service has that. And when I worked in general urology, I'd be teaching intermittent catheters on the ward, and then I'd never see that patient again. It was just a whole sort of disembobulated type service. And I think what's my feeling is, I want the patients to know everything. I want them to have choice. I want them to know all their options. I want to know all the latest stuff that's out there that's specific to them to help them. And if you go to, but we do need our local continence services. We can't do without them. They're absolutely essential. But I also feel that each patient should have that contact with an expert or a specialist overarching to make sure that they are aware and fully informed of everything that's available for them and adapting to their particular. But also then you can have that support from your local teams to support them within their home environment, because I can't go to their home. I'm hospital based, and some of my patients are in Cumbria and I'm in Stanmore. I've got some in Gibraltar. I can't go and see them all, and that, so you do have to look at your local community services, but I also really appreciate how stretched they are as well. And I have had occasions when someone from another hospital has rung me and said, look, I've got a 6-month wait to teach somebody intermittents. Can you help us out? Of course, we'll try and help you out. Don't everyone send all your patients to me, though, please. But I think it's really important that, particularly post-COVID and recovery, we do help each other out. And if one service is struggling, it's about reaching out across your networks to say, look, I'm struggling in this area, but not in another. Can you help me out? And I'll do the same for you in another.
Just quickly, Mandy's asked whether you would consider using the Queen Square bladder stimulator as an interim treatment option if they're not wishing to start ISC at the moment.
Well, I can share our experience. So I think if we deem the upper tracts are safe, and it's sort of a borderline post-void residual volume, then I think particularly with MS patients, it's certainly worth trying. And some patients we do find manage well without needing catheterize.
Thanks, Jalesh. So Liam's also commented, I have a patient who has used the same ISC for 5 years, and he's popping it in Milton and he's never had a UTI. So I guess there is all those, like you said, Sharon, there's lots of historical ways of using equipment and ways patients are actually coping.
It's so random, isn't it? It's fascinating.
And then probably the last question, someone's asked, how does Ialuril work? Who'd like to answer that? Sharon?
Let me go back to my slide.
Essentially, it replenishes the gag layer, and
Yeah.
in short, but I suppose the backside about mechanism.
So basically, it's replacing what the gag layer is made up with, which is water and this it's hydrolonic acids, chondrite sulfate, and calcium chloride. So it's building back up that gag layer. It's building up that natural resistance again. And certainly, it's used not just for recurrent urinary tract infections, but you can use it with interstitial cystitis or bladder pain syndrome, which is a horrible condition to have, and also for chemical or radiation-induced cystitis of people with bladder chemotherapy and radiation. And that's certainly my experience with particularly spinal cord and some MS patients has been absolutely brilliant. And this is where everything else has failed. We've checked their technique of intermittence. We've ultrasounded them. They've got no stones. They've done all the natural stuff, cranberry, D-mannose, probiotics. We've done low dose antibiotics, and they're still getting really bad symptomatic breakthrough UTIs. And Uro-neurology has just been a game changer for them.
Thanks, Sharon. Someone's asked if we could share the questionnaires that have been mentioned during the talk. So yeah, absolutely. Very happy to share the links. We can put that online, maybe where the webinar is once we have the recording, if that's okay with Jalesh and Sharon. I don't know if you two have any other last comments before we close.
I think there was a question that's come from Jill about what types of probiotics would you recommend?
Probiotics, you can have either the drinks, the Actimel Yakult-based drinks, or the live yogurts. I think kefir is a live yogurt. My mother-in-law swears by that. You can also, if you don't like the yogurt or the drink, I don't like the drink, but I like the yogurt, you can get probiotic tablets as well. They're little capsules.
And there was a question about Hiprex, and I think there's been a randomized control trial about methenamine that showed reduction in UTIs, not specifically in neurological patients, but in urological patients in general. And so certainly something that we use at Queen Square.
We certainly use it as well. I get some problems actually with GPs agreeing to prescribe it, interestingly, and I think long-term use, there's some indicators, I think, for liver function that you have to be aware of. Jalesh, correct me if I'm wrong there, but yeah, we do use recommended Hiprex. It's an what's the word? It's not an antibiotic. It's sort of like it's an antimicrobial, isn't it?
Like an antiseptic, yeah.
Yeah, antiseptic based thing.
We've had one more question come through just quickly. Maybe that could be the last question. What do you see as the role of sphincterotomy in overactive bladder?
Actually, I mean, certainly not in our progressive neurological conditions. I suppose when you go to neurology meetings, there is a small cohort, but not many who require sphincterotomies for avoiding dysfunction.
It was always considered a very good and cheap option because you cut the sphincter, they have sheath drainage. Obviously, it's only for men, not for women. And for a period of time, they'll do really well and empty their bladders. However, they're technically incontinent from a dignity perspective and from a quality of life. But some patients are happy with that. However, as soon as you cut the sphincter, and it's normally the external sphincter they may probably cut rather than necessarily the bladder neck, or if they do cut the bladder neck, the other one would become dysenergic. So what we find is that when you have a sphincterotomy, you then get it repeated 5 years later. And because they've always got this underlying horrible kind of urine, we find then their risk of going septic during that procedure is very high. And I've had a couple of patients had to go to ITU post-op for severe urosepsis following a sphincterotomy. So it has a place, and I certainly know in certain countries it's a cheaper option than paying for intermittent catheters all the time. However, patients now have kind of moved on, and it's about choice. If they want that, that's fine, they can have it, as long as they understand the consequences, that it's not a one operation and that's it. You might need it done again, and there are risks going forward. But ultimately, I haven't got anyone that's chosen to have one now.
Thanks, Sharon. We have had another couple of questions, but we'll answer them on the website if that's okay. So once the recording is uploaded, we'll answer it then. Janae, if you could go to the next slide. Just wanted to say thank you so much to Jalesh and Sharon for joining the webinar today. It's been really interesting, lots of information. For me, my take-home messages is don't rush, get the facts, and it's about patient choice, and that's all the way through from beginning to end. So just quickly, next slide, please, Janae. So what we thought was, because we were discussing a little bit around us and looking after ourselves, we do have this health and wellness on demand course. Would highly recommend it. It was put together by Charlie Peel, who is our health writer, and it's very much for you. It's very much supporting us through the difficulties that we're encountering at the moment to look after ourselves. So do have a look at that. It's on demand, so you can complete it as and when you have time. So I just want to say a big thank you to everyone for joining us today. Thank you to Jalesh and Sharon for speaking, and we look forward to next time. I don't know if you want to say anything, Jalesh, in closing.
I think it's been a great sort of webinar, and thank you, Sharon and Ruth. But thank you, everyone, for joining.
Yeah,
thank you. It's been lovely.
And just quickly, we will have more education for uro-neurology later in the year. So please do watch the space, and we look forward to seeing you next time. Thank you.